Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
This activity includes discussion of off-license or unapproved therapies. Please consult your local SMPC or its equivalent for further information.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Servier.
Hello, everyone, and welcome to this program that will cover integration of IDH inhibition into therapy of glioma care. This program by Medscape is a summary of a program that we had at the major neuro-oncology meeting recently. My name is Maciej Wrogawa. I'm a neuro-oncologist at Mayo Clinic in Phoenix, Arizona. And I had the pleasure of hosting two panelists, Dr. Rimas Lucas, professor of neuro-oncology at Northwestern University in Chicago, as well as Dr. Yoshi Umemura, a chief medical officer from ID Brain Tumor Center in Phoenix, Arizona. Today, we will discuss the role of IDH inhibitors in treatment of glioma, and I will start by discussing the story so far. Gliomas are uncommon in general population, but central in neuro-oncology practice. Most gliomas encountered clinically are high grade. However, low-grade gliomas account for about 2,000 to 3,000 cases per year in the United States. Up to 80% of low-grade gliomas harbor IDH1 and 2 mutations. And IDH mutant gliomas affect younger adults. As you can see, roughly the median age is about 37 years for astrocytoma and 45 years for oligodendroglioma. The disease is chronic and can be life-altering. IDH mutation confers a major prognostic advantage. As you can see, patients with mutated tumors live significantly longer than patients with IDH wild-type tumors. WH classification of gliomas and other central nervous system tumors has been evolving over the years. As you can see, these first 4 editions of WHO classifications have been getting thicker and thicker over the years. It appears that the next edition of WHO classification will be released in 2027. Classification in 2016 introduced integrated molecular diagnosis. Further, in 2021, it was refined by adding new entities, new approach to grading, as well as new nomenclature. IDH mutation status is essential for diagnosis, grading, and prognosis of these tumors. As you can see here, this theme has also been evolving, with IDH mutation being used for molecular characteristics and classification of the tumor, and also more recently for grading. These discoveries and IDH mutation status has been used by different guidelines, specifically ASCO and SNO guidelines, as well as NCCN guidelines, to guide clinicians in terms of diagnosis and treatment management of these patients. In addition to pathology, IDH mutations can also be used for diagnosis of these tumors and disease monitoring by checking the metabolite, specifically 2-hydroxyglutarate, either by liquid biopsy or using MR spectroscopy. Treatment of IDH mutated gliomas in the pre-IDH inhibitor era was mostly focusing on surgery, as well as then either a chemotherapy or radiation. In patients with favorable prognosis, for the most part, wait and see approach has been implemented. However, for patients with high-grade disease or less favorable prognostic factors, radiotherapy followed by chemotherapy has been recommended. In clinical practice, there are, however, multiple different scenarios for IDH inhibitor use. Many clinicians today are struggling sometimes in clinic in terms of how to best approach the patient. The following scenarios are common. One is use of IDH inhibition following resection and before radiation and chemotherapy. This is a relatively easy decision to make, as this particular scenario is along with the labeling of the currently approved IDH inhibitors. Other scenarios include progression after first IDH inhibitor. Another very common scenario is the possibility of switching from an older version, maybe the first generation of IDH inhibitors, if you will, to the approved version, which is vorasidenib. There are also questions about using IDH inhibition in patients prior to resection. Very big problem in neuro-oncology is enhancing disease. Most of the low-grade diffuse IDH mutated gliomas are non-enhancing. However, occasionally we are facing a situation where enhancing disease is present, and clinicians are trying to decide what to do in this scenario. And of course, the most difficult situation is grade 3 disease, where we do not have established pathway in the era of IDH inhibitors. Let's go over the seminal Indigo study that led to the approval of vorasidenib for use in patients with IDH mutated grade 2 gliomas. This was a phase 3 study. It was randomized and placebo-controlled. It was designed for patients with measurable non-enhancing disease and patients who did not need immediate chemotherapy or radiation per investigator assessment. Patients were randomized in a 1-to-1 fashion to either vorasidenib at 40 milligrams or placebo. A crossover was allowed when radiographic progressive disease was assessed centrally. The primary endpoint was progression-free survival, and there was also another interesting endpoint, time to next intervention. When we look at the results, we identified that progression-free survival was significantly longer in patients in vorasidenib arm as opposed to placebo. And you can see here 27.7 months versus 11.1 months. The second endpoint, which was time to next intervention, you can see that in vorasidenib arm, the endpoint has not been, time has not been reached. In placebo arm, the time to next intervention was 17.8 months. Safety analysis indicated that the medication was robustly safe. The main side effects were liver function abnormalities, a few cases of hypertension, as well as mild neutropenia. Generally, discontinuation rate due to treatment was very low at around 3.6%. Another important finding from this study indicated the possibility of reduction of seizure frequency. Patients enrolled in the study were assessed for seizure frequency. Only patients with controlled seizures were included, and anti-seizure medications were at the investigator's discretion. Patients were using self-reported diary, where they would record the number and severity of seizures at each cycle. The subgroup analysis was conducted. Patients with one or more seizures, reported seizures, were included, and then seizure activity was calculated using a negative binomial model, which is commonly used in epilepsy trials. A model was adjusted then for a baseline seizure and number of stratification factors for the patients. It was discovered that there was a significant reduction in seizure frequency in patients in vorasidenib arm of about 64%. Also, another measure indicated that seizures were fewer, about 2.8 times fewer per person per year in a treatment arm. Additional analysis just published recently indicated that the effect of seizure reduction was much more prominent in oligodendrogliomas as opposed to astrocytomas. Based on the clinical trial data from Indigo that were published in New England Journal of Medicine in August of 2023, vorasidenib was approved for patients with IDH1 or IDH2 mutation and low-grade glioma characteristics who have had surgery but not had radiation and other treatments. Subsequently, vorasidenib was approved in the United States in August of 2024. Following the approval in the US, the medication was then approved in additional countries. And as you can see on this map, is now available in other North American countries, in South America, most of Europe, the Middle East, Australia, and Japan. Looking at the survey data, it appears that faster adoption of the vorasidenib occurred in the United States, mostly in the academic center, as opposed to community or most European settings. So how do we approach treatment of gliomas in IDH inhibitor era? Usually after a biopsy or surgery, and the goal is to always achieve maximally safe resection. And upon the diagnosis of oligodendroglioma or astrocytoma grade 2, patients can follow different pathways. In case of a complete resection, the watch and wait approach can be implemented, or use of vorasidenib is appropriate. For patients with residual recurrent disease that do not need immediate radiation chemotherapy, typically vorasidenib is recommended. And finally, the third group of patients are patients that we call high risk, even though high risk criteria are not uniformly agreed upon. This group of patients is typically treated with radiation, followed by PCV or temozolomide. Many questions, however, still remain. We are still trying to decide who to select for an IDH inhibitor therapy. Frequently, in clinical scenarios, we are facing a situation where upfront cytotoxic therapies might be used, but are they appropriate? Can IDH inhibitors be used upfront in an upfront setting? What to do with grade 3 tumors, and specifically tumors that are non-enhancing versus enhancing? We know from the data from Indigo study and other studies that IDH inhibitors work best for non-enhancing disease. What is the best salvage therapy? What is the best combination therapy? And finally, what practical criteria can be used to help make decisions in real time in a multidisciplinary conference? To help us answer some of these questions, there are multiple ongoing clinical trials with IDH inhibitors. There are many studies that are using vorasidenib as a backbone, with addition of temozolomide, pembrolizumab, and other agents. These are studies between phases 1 and 3, and they include patients with grade 2 and 3 disease. It will be interesting to await the results of these studies to see if new signals and new indications emerge. There are also studies using novel IDH inhibitors and testing them in different clinical scenarios, specifically in patients with grade 2 and 3 disease. Many of these studies continue to be phase 1, but hopefully we will see many more phase 2 and phase 3 studies in the future. We now have all the clinical trial data, but how are we using IDH inhibitors in clinic? And one of the goals of our symposium was to answer this question and see how clinicians are using vorasidenib in a real world setting. We identified several challenges that clinicians are facing with patients with IDH mutated gliomas, and I will share them with you in a moment. We were able to discuss these challenges with our faculty as well as the audience present at our live meeting. Many logistical hurdles apply to the patients who are diagnosed with IDH mutated gliomas. These patients are frequently very young, and face major life-challenging events such as family planning, also fertility preservation, medication adherence, medication availability, insurance challenges, as well as other concerns. One of the main challenges is global access to IDH inhibitors, specifically vorasidenib, as it is not approved in all countries at this point in time. This can result in challenges for the patients in terms of choosing the right treatment. Another important clinical problem is presence or absence of enhancing versus non-enhancing disease. Generally, enhancement on MRI is a proxy for more heterogeneous and potentially aggressive disease, frequently associated with potentially higher grade. And it has been shown that better response to IDH inhibitor is seen in non-enhancing disease. Nevertheless, in clinical practice, we frequently face a situation where some parts of the tumor could be enhancing and histology could be indicating a lower grade of the disease. We are then facing a dilemma, which medication or which treatment type to choose for our patient. So let's walk through several cases that we prepared for this meeting to show you the real world challenges that we all face in clinical practice. We were able to obtain polling results from the audience during our live meeting, and I will share some of the polling results with you in a few moments. Let's talk about the first case. The first case is a patient who is a 49 years old woman. Patient's initial presentation was a seizure about 10 years prior to these events. Initial management included craniotomy with gross total resection, with pathology revealing oligodendroglioma WHO grade 2. Patient was initially followed radiographically, then progressed, and at the time of progression underwent another resection. It was a subtotal resection. Pathology identified oligodendroglioma WHO grade 3, and patient was treated with temozolomide and followed radiographically. Following the use of temozolomide, seizures have recurred. Patient was managed with 2 anticonvulsants, but despite 2 anticonvulsants, she was facing additional seizures, and MRI showed increase in the non-enhancing FLAIR abnormality. As you can see on the picture to the right, there is a resection cavity surrounded by the abnormal FLAIR signal, more prominent in the posterior aspect of the lesion, indicating likely tumor growth. The question about this case was how to proceed from here. Some of the panel members were favoring IDH inhibitors, given the fact that the patient have been having seizures, and IDH inhibitor could achieve potentially 2 goals. One would be decreased rate of growth of the tumor, and the second one could be a decrease in the frequency of seizures that the patient was experiencing. This would also allow for a delay of radiotherapy, which the patient was not in favor of. Some panel members were concerned that the tumor has now evolved into a grade 3, and they believed that using radiotherapy in this setting would be potentially more appropriate. There was also a discussion about the possibility of re-challenging with temozolomide, but this was considered less desirable given the fact that the patient has previously been treated with the medication, and temozolomide alone might not potentially work well for this patient. Surgery was also considered. However, given the location of the disease, it was believed that it could be associated with increased morbidity for the patient, and it was not favored. Generally, the consensus for this case was that IDH inhibitor could be a very reasonable option. Reasons provided were the presence of non-enhancing progression, which, as we discussed before, seems to be an ideal choice for an IDH inhibitor. Also, seizure-related impact might be significant, especially with the most recently presented data, and the patient reluctance to radiation. So that would really go along with patient wishes to proceed with treatment that would not involve radiation. We need to, however, emphasize that at this time, radiation remains a standard of care for grade 3 tumors. An IDH inhibitor may delay but not replace radiation, at least at this point in time, although, as I mentioned before, clinical trials are ongoing. Let's go to a second case. This is a 42-year-old man with a left frontotemporal tumor. Patient underwent a biopsy of the disease and was diagnosed with diffuse astrocytoma, IDH mutated, CNS WHO grade 3. Based on this diagnosis, it was recommended that the patient is treated with radiation as well as temozolomide following radiation. He actually also received concomitant radiation and was then seen in consultation after having completed 7 out of 12 cycles of planned radiation. This is the imaging of this patient showing a large, predominantly non-enhancing tumor encompassing mostly left frontal lobe and causing a midline shift as well as mass effect. In this particular case, the question was what to do next. We polled the audience during our live meeting, and the responses we received were quite scattered. Some audience members were recommending surveillance after completion of 12 cycles of temozolomide. Some colleagues in the audience were recommending continuation of temozolomide beyond 12 cycles. Some recommended switching to an IDH inhibitor, and some others suggested a combination of therapy, so basically adding vorasidenib to temozolomide. Our panel discussed this case. Overall, it was concluded that standard of care in this situation should be surveillance after completion of chemoradiation. It was truly believed that continuation of temozolomide believed 12 cycles would not be recommended, and that was based on the fact that significant bone marrow suppression can occur with increased exposure to alkylating agents such as temozolomide. The risk of therapy-induced bone marrow suppression is high in this setting. There's a risk of therapy-induced hypermutation in IDH-mutated tumors after exposure to alkylating agents. And there is also a diminishing return in terms of survival of the patient and life prolongation. In terms of using an IDH inhibitor as a maintenance in this setting, this was considered to be potentially reasonable, but not evidence-based. Some neuro-oncologists offer IDH inhibitors for extensive residual disease. So in this case, there likely would be extensive residual disease, but it wasn't necessarily believed that using IDH inhibitor following the treatment with temozolomide would be recommended. Some of my panel members would say that they would not routinely start IDH inhibitor without supporting data. So the bottom line is that at this point, we truly do not have the data for recommendations to use IDH inhibitor in grade 3 tumors, especially in the setting where they were already treated with radiation and chemotherapy prior. Key points from this case: practice patterns can vary widely, as we have seen by polling our audience. Evidence for IDH inhibitor as maintenance therapy in grade 3 disease is currently insufficient. Let's go to our last case. This is a 43-year-old patient who presented with facial numbness and drooling. He underwent an MRI that showed a right frontal mass with increased perfusion, and accompanying EEG showed electrographic seizures. Patient underwent a biopsy of the lesion because resection of the lesion was deemed too risky, and I will show you the MRI of the patient in the next slide. Patient was placed on two anticonvulsants, lacosamide and levetiracetam, for seizure control, and he actually responded quite well. And the biopsy, most importantly, showed diffuse astrocytoma, IDH mutated WHO grade 2. This is the MRI of the patient showing abnormal T2 flare signal abnormality. You can see this on two sections. The post-contrast images, which I'm not showing right now, did not indicate presence of contrast enhancement. And so in this particular setting, our panel discussed several options. The most favored option for this patient was surgery. However, as I indicated before, the surgical team did not feel like surgery could be complete and achieved safely in this case, so biopsy was chosen. Our panel discussed that if resection is not feasible, the use of IDH inhibitor upfront could be an option. And the main reason for that would be to delay chemoradiation. There was also a discussion about using temozolomide with radiation, and it was believed that it could be deferred given the grade of the tumor. One important point of the discussion of this case was the fact that IDH inhibitors rarely shrink tumors significantly. And the main goal and the main benefit of IDH inhibitors is the kind of a delay of progression. So relying on the potential shrinkage of the tumor in response to IDH inhibitor to make surgery more feasible should not really be considered, as this rarely happens. In terms of the outcome of the presented case, the team favored use of vorasidenib first to avoid radiation and surgery, and also respecting the patient preference. The patient specifically did not want to have a radiation early on. Additional points of this discussion were have to do with recurrent IDH gliomas. Sometimes IDH inhibitors are used in cases of slow, radiographically subtle progression when patients want to avoid chemoradiation. And also, they are not preferred for patients who have rapidly progressive or enhancing disease, as we discussed before. These cases have shown us that there is a lot of real-world scenarios where we don't really have a straight answer in terms of how to proceed. Generally, IDH inhibitors are changing the management of low-grade IDH-mutated gliomas, but there's a lack of evidence for many of the real-world scenarios, specifically maintenance therapy, use in grade 3 disease, and use in recurrent disease. I think it needs to be emphasized that we should look at patient's preference as well and quality of life, and adjust the treatment to what is important to the patient, what stage of life the patient is in, and how long the tumor natural history is to weigh heavily into decision making. There is also substantial practice variability across the institutions, as we have discovered during our discussion, as well as through polling of our audience. So to summarize, new treatment options for IDH-mutated gliomas now exist, and IDH inhibitors represent a novel class of oral targeted therapies that are designed to treat gliomas with IDH1 and IDH2 mutated tumors. There is a clinical promise that has been really very nicely shown in the phase 3 trials, demonstrating statistically significant improvement in both progression-free survival and time to next intervention against placebo. The impact of tumor growth has been demonstrated, the data suggesting that this class of drugs may delay progression and lower tumor growth rate, potentially offering clinical benefit beyond delaying traditional interventions. The safety profile of this approach appears to be quite good, with very manageable side effects and very low discontinuation rates in patients placed on these medications, specifically vorasidenib. But we also need to realize that evolving treatment landscape is present. We see not only evolution of the initial IDH inhibitors in terms of clinical trials, pairing them with other agents, but also development of the next generation of IDH inhibitors, which potentially will offer new hope for patients with challenging cases, and specifically with patients who have a higher grade disease or disease that has not responded to other forms of treatment. Thank you so much for your attention, and thank you for participating in this Medscape program.